so already, remember there is a gala dinner and you have to go to the registration desk to select your seat. Now, the other thing I need to remind you is that you need to complete your exhibition passport, or you're not allowed to, and return your entry to the registration desk. Tonight's gala dinner will take place in halls F and G of the Convention Centre, and it starts at 6:45, and bring your ticket with you. Now, the other thing to remember is that your nearest exit, I reckon, is that hole in the wall, and in the event of an emergency, follow the instructions of the Convention Centre staff, because me and Dave have no idea what to do. First up, Mostafa Alwan. Would you like to take the stage, please? So Mostafa is a PGY3 undertaking a surgical residency at Monash Health, and he has a very important question. Should clinicians predicted imminent and within 90 days death be excluded in clinical trials? Over to you.
All right, thanks. All right, good morning, everyone. My name is Mostafa Alwan. Like I said, I'm one of the surgical registrars at Clayton, Melbourne, doing my general surgery time. This is just a short project I did during my ICU term. Should clinicians predicted and imminent death within 90 days death be excluded from clinical trials? Thank you. So a background to this study is, so many trials often exclude patients that are deemed likely to die within 24 hours or within 90 days, and this is often left to the clinician's judgment. The potential downfall of this is inaccurate identifications of patients may lead to skewed trials by eliminating the most ill patients, and also may incorrectly identify patients who will then go on to survive, predicting them to die imminently, and may lead to underpowered studies. So what we did is, throughout the years of 2016 and 2017, we pulled up the exclusion logs from the trials conducted at 2 of our Metropolitan Hospital ICUs. We screened those logs, found all the patients that were excluded from trials due to either predicted death within 24 hours or predicted death within 90 days. And those patients' records were then pulled up from our scanned medical records system, and we looked at all their demographics, and most importantly, we looked at whether or not they actually died in the time criterion estimated or died at all. Other demographics collected included their Apache scores, their duration of invasive ventilation, duration of vasopressor support, and duration of renal replacement therapy. Okay, so in 2016 and 2017 at our 2 hospitals, we had about 7,000 ICU admissions, and from all those, I didn't have all the numbers, but some of them were included in trials, and then some of those were excluded, and of the exclusions, 76 patients were identified as part of this study. So 50 were excluded. Oh, well, they were included in this study because they were excluded from other trials as likely to die within 24 hours, and 26 were, again, excluded from other trials because they were predicted to die within 90 days. Okay, so just some demographic information. I've grouped them into 3 groups. So all the patients, imminent death means death within 24 hours, and it's predicted, and death within 90 days means predicted death within 90 days. So as you can see, the thing that stands out the most straight away is the age of those predicted to die imminently was 80, whereas the other 2 groups, are 60 to 70. The spectrum of their ICU admitting diagnoses was similar throughout. So it was sepsis, cardiac arrest, or post-operative complications with 2 variceal bleeds. The Apache score for all 3 groups was similar at around 30. Pretty much all the patients received invasive ventilation. Pretty much all of them received vasopressor support, and around 25% received renal replacement therapy. In comparison to the 7,000 patients that were just admitted to our ICU, their mean Apache score was 16 to 17, so this group had a higher Apache. 60% of them were ventilated, so obviously this group is higher ventilation. 5% dialysis and 50% vasopressor support. So this group really received higher, more frequent therapies of all of these kinds. Yep. and a breakdown of their comorbidities. So heart failure, COPD, chronic liver disease, chronic renal failure, malignancy and diabetes shows a fairly even distribution amongst our patients, and this didn't vary too much from the standard ICU patient. Okay, and the interventions that they received. So hours on vasopressors, median and IQR. So as you can see, a lot of it was quite same, spread out through all the groups. Hours on invasive ventilation, the group within 90 days had a higher group than the other two. It's important to remember that the date from which they're screened is not the date that they're admitted. So sometimes patients would come to ICU and stay in ICU for a few days, and then the consultant or registrar would screen them, and then they would die. So yeah, sometimes that skews the numbers here a little. But yeah, as you can see, their median ICU length of stay in hours was 46, 58 and 45, and for all our patients the median is 46.5. So this group didn't actually stay in ICU longer than our normal ICU patients. And again for the hospital length of stay. Okay, so what the results showed. So this is all the patients grouped together, all 76 of them. And as you can see, out of the 76 patients, 26 of them, so that's 34%, died within 24 hours. Another 26, so another 34%, died after 24 hours, but within that same admission. 5 patients, so 6.5%, they survived their hospital admission, but later died within 90 days. And 19 patients, so 25% of all of those screened, survived past 90 days, which we used as our kind of end outcome. Okay. And this is of the group predicted to die within 24 hours. So we had 50 patients in total that were predicted to die within 24 hours. And a bit more than a third, so 36% of them did die within 24 hours. However, a similar number, so 18 patients, 36%, died after 24 hours. And 14 patients survived. So they were predicted to die within 24 hours and made a complete recovery and went home. And this is the group predicted to die within 90 days. As you can see, it seems that clinicians are more accurate at determining death within 90 days. So this group died during the admission, and all their admissions were less than 10 days of length. So this could state died within 10 days, for example. So that's 69% of patients. There's 12% of patients were discharged home, but then subsequently readmitted and died within 90 days. And 5 patients, which is 19%, survived past 90 days. So a total of 21 patients out of 26, so 81% of patients who were predicted to die within 90 days did die within 90 days. So that's the result. So in the discussion of this, it seems that predicting death of critically ill patients, it remains challenging to accurately identify who will and who won't. It's often left to clinician judgment. And I noted that when I was going through all the exclusion criteria and when I was looking at other studies that also excluded patients for similar reasons, it's not often the rationale for why they're excluded isn't really kind of mentioned. It just says excluded as per clinician discretion. But obviously clinicians are more accurate at predicting death within 90 days. I mean, it's hard to say exactly why, but this could be potentially due to a higher burden of disease, or it could be due more to kind of pre-existing conditions determining their 90-day mortality rather than their acute presentation. Yeah, and again, excluding patients with a high risk of death may lead to underpowered studies and a skewed patient population. In terms of how this affects studies, so often when we conduct randomised controlled trials, we base our predicted mortality and our predicted outcome based on observational studies. And we often use the predicted outcome from the observational study to calculate a sample size. And observational studies, of course, don't exclude patients who are at risk of imminent death or death within 90 days. And this is how it can lead to underpowered studies. I just did a really quick, just as a really quick example, I went onto PubMed and I found this is one example of a study that this happened to. So in 2014, this group did a randomised trial of dividing patients into 3 groups based on the management of early septic shock. Based on their observational studies at their department, they predicted a mortality of 30 to 46% for all patients with septic shock. And the study was aimed at least an 80% power to find a reduction in mortality of 6 to 7% with their specific protocol that they wanted to test as opposed to standard treatment. And an interim analysis was planned after 650 and 1,300 patients. So they predicted the 30 to 46%, and they wanted to be able to predict a mortality reduction in their new algorithm of 6 to 7. But when you look at their numbers, they enrolled about 1,351 patients. They actually excluded 264, and I tried to find the Apache of the excluded or any information about them, and unfortunately wasn't provided. But if you look at the Apache score of their patients, as opposed to the patients that were excluded for hours to die, their Apache score sits at about 20. Excuse me. Whereas ours was sitting at about 30. And then if you look at their results, they had to abandon the study at about 3/4 of the way through, and in their discussion it says potentially due to a lowered sample size. They predicted their actual tested mortality was far lower than what they had. So this is just a quick example of that. And this is my conclusion. So there remains scope. This is just kind of a first step to say that predicting patients who are going to die within 24 hours isn't kind of perfected yet. And this is just a first step to say maybe we could develop a criterion in the future to make it more accurate or more standardised. Thank you.
Thanks very much. That's a very original study to do, and congratulations.
Thanks.
What I'm wondering is, were you able to compare, or are you thinking of comparing the patients with the same Apache score who actually were in the trials and what their mortality rates were? An example's already been done. Catherine Deans in 2005 looked at the ArsNet patients who were excluded from the original ArsNet study, and found those that were excluded had exactly the same mortality as the intervention group, for example. So I think that to continue your work, that would be really useful to look at, to see what the difference is in the ones who were enrolled with the same Apache and those who were excluded.
Yeah, thank you.
Thank you. Further questions?
Cheers, that was very clever. I liked it. I guess I've got the question I was wondering is, let's say that you were in charge of running a large-scale randomised controlled trial. How would you change or modify your inclusion criteria based upon your study?
Yeah, that's a really good question. So that's what I was discussing with the supervisor of this project, was Professor Shahabi. I guess, look, I don't know. This is more of it's like a first step to say that this situation exists. So obviously, smarter, more experienced people than myself would have to come up with a criterion that's more accurate.
Very good answer.
I'm pointing at the hole in the map, not exploring it,
Not sure why he was looking at you when he said that, Jeremy. Any other questions? Yeah. How are we going for time in the day?
Yeah, we're good.
Okay.
Try and say something. So I'm interested. So basically, I think you're saying that about 1 in 4 or 1 in 5 of patients who we exclude from clinical trials because they're predicted to die actually survive.
Yeah.
This does reduce power, but with randomisation, I think the randomisation algorithm will mean that both groups are equally affected.
Yeah.
So I'm just trying to think through what the implications of that are, because some clinical trials, and let's take the current PLUS study, okay, that's being done. I think the power calculations based on data from a previous randomised controlled trial, nice sugar, rather than the observational study. Okay. So given that that's present in the PLUS study, I'm just trying to think through how does this affect the fact that it's probably going to be balanced between the two groups? Can you think that through for me? Because I can't think it through.
I think it's a tough question. That is a tough question. If it's balanced between the two studies, I guess it might not affect the studies. But if you were testing the mortality outcome of certain interventions like the septic shock, you're testing an algorithm for septic shock. I imagine in real life you would start using that algorithm for everyone. If you wanted an accurate predictor, maybe you should include... Do you know what I mean? Like you could... Yeah.
Flurry of questions. I think... Sorry, Glenn, we just got time for one more question.
Thanks for that very nice presentation. Do you have any information on the patients who were entered into the trials who then died in 24 hours? In other words, how often did they get it wrong the other way?
No, I don't, but that's a good question. Sorry.
Because then you can do sensitivity, specificity.
Yeah. We plan to publish this, so that would be something we'd look into then. Yeah.
Mostafa will be available for further questions at the end of the session.
Thank you very much. Boris is an intensivist and general physician and works at Austin and Epworth and La Trobe. And Boris is going to be talking to us about the nature and impact of in-hospital complications associated with